Hey, Srini, yeah, Chris Metzger, I can hear you fine. Can you hear and see us okay?
Yes, great, great.
Fantastic. You want to tell me who's on your panel, and then I'll introduce what we have and take it from there.
Sure, sure. We've got Dr. Babave, we've got Dr. Finelli, Dr. Garcia, Dr. Genovese, Dr. Kum, Dr. Nakama, and Dr. Purushottam, and Dr. Sisemski. Those are our panelists for the day.
Fantastic. Well, we talk about an all-star team, that it is. So welcome back to Kingsport, Tennessee. We are honored and thrilled to transmit from Ballad Health, Holston Valley Medical Center to the New York Endovascular Symposium again. We have good cases here. I've just been back 2 weeks, 2.5 weeks, reunited with my friends here, and they've done a great job. Before we start with the case, I want to introduce this great team. We've done some really serious rearranging of the furniture here for this case, and they overcame every obstacle. So let me introduce them first. To my right, running the table, the most important job here, keeping me under control, is Sydney Almany. Okay. Behind her, we've got the nursing talents of Alec Gray, Holly Bragg, and the nursing and technical skills of Courtney Jones. We also have a lot of industry folks here, including Josh from Boston Scientific, who pulled a rabbit out of his hat the last hour, and thank you, Josh. So let's go to our case, please. You see our slides? Srini, can you see the slides?
Yes, we see everything, Chris. Thank you.
Okay. All right, next slide, please. Here are my disclosures, which won't affect this. Next slide. All right, this is an extremely pleasant 60-year-old gentleman. He's a parole officer and worked in the prison system previously, both chasing and keeping the bad guys in line and helping rehabilitate them. He doesn't have coronary disease. He does have some ongoing tobacco that he's working on, and we're going to work harder. And he had a really significant right flush ostial SFA occlusion. We'll give you a brief glimpse to that in a moment. And in 2021, we were able to cross that and treat it with large interwoven stents and a large drug-eluting nitinol stent. From 2021 until 2025, his symptoms had completely resolved. He was doing fantastic. He was on good medical therapy. Next slide. So this was his intervention in 2021. You could see the osteal, kind of a tiny bit of a nub there, and then a long occlusion, reconstituting with good 3-vessel runoff. Okay, next slide. We really had to probe at that back then. We ended up having, you can see on the panel, it kept prolapsing into the profunda, but we were able to get a straight glide, dig in there, and then ultimately on the other image, you can see we were able to twist there and get into the true lumen and stay true luminal. Next slide, please. And at that time, we end up, because of some dissection after, we did a lot of pre-treatment and vessel prep, but ultimately put very large interwoven stents. Lawrence will tell you about the primary patency from the Superb trial. These are even bigger than using the Superb. And then you could see we tried to stick the landing at the ostium there of the SFA. Next slide. And here you can see on the right the nice osteal location and the good final runoff. Next slide. So while I was still in Ohio, he developed a really bad claudication relatively suddenly in May while mowing the grass. And it was started on Celastazole by a nurse practitioner here, walking program. ABIs were 0.61 and dropped significantly. With exercise left was pretty normal. CT angiogram showed what you're going to see here in a moment, occlusion on the right SFA stents, reconstituting with delayed but good 3-vessel runoff. And again, he had severe lifestyle limiting and vocational limiting. Again, works in the prison system on maximized medical therapy and walking program. I saw my friend here back in consultation on return, and here we are today to kind of fix things. All right, next slide. All right, let's go to our fluoro, please, and we'll show you what we've done so far and then get some wisdom from the panel. So like all of us, we use vascular ultrasound to get access. It allows you to get it right in the middle of the femoral artery, which is a nice big one. You can see that he has some ectasia, but really no significant disease in the renals or aorta, iliac. We like to find a good angle. You can see down at the bottom of the screen the osteal occlusion there, and we use that as the smart map, and then get a glide wire deep into the profunda, change out for a support wire, and then bring our sheath up and around. We had little glitches here with our system here. It's changed a little since I was here a couple years ago. So you see little white flashes, bear with it, but you see the gist of the issue there. Stent occluded very proximally, reconstitutes at the distal end of the stent. And although it takes a long time, consistent with the ABIs and such, there is a good runoff down there. So we'll stop there for just a second, and let's get some opinions from the panel. So we've got large interwoven stents and a large nitinol stent, patent for 4 years, refractory. What kind of strategy are we thinking for the panel? What's our ultimate end game? Do we use protection? Do we not use protection? How do we clean the stents out if we do? And then what's our ultimate game? Let me hear from the panel, and then we'll get to work here in a moment.
Thanks, Chris. A couple of quick questions. Maybe you touched on this already. Was he still smoking, and how long has he been symptomatic?
So he's been symptomatic since May. Again, tried walking program, maximized medical therapy, including silastazol at 100 twice a day, DAPT, yada, yada. He is still smoking. He is working on it. We're going to work even better. I offered him what I like to call the Metzger steak dinner challenge, which if he tells me quit smoking, he and his family get a steak dinner on me. But he's still smoking, but working on it.
Okay, great. So maybe we can take some opinions from the panelists. You said has no coronary artery disease. He's still smoking. He's obviously was medically managed appropriately, exercise program and so forth. We've got Tasaka Class 3 ISR here. What do the panelists think in terms of what's the best way to treat this? And this really gets into the discussion, which we can talk about later. How many times do you intervene on stents that have gone down? That's a very hot topic right now. So maybe we can start here and head down.
I'm just curious, do we know the status of his GSV?
Does he have a vein?
He does have a good vein, Liz. He's not ready for it yet. The initial question was how many times. I give him a second chance, but it's a good question. He's not critical limb ischemia. He's got lots and lots of claudication, but you raise a good point. We should at least vein map and make sure. I've only been back a couple of weeks. We couldn't get the vein mapping in. It wasn't going to change what we do or not do today, but great question. And certainly if it goes down again, and we may even get his vein mapping while he's here.
So Liz, maybe you could tell us in your practice, how many times do you intervene when you have a patient in this situation with ISR? In this case, obviously it's an occlusion.
Yeah, I mean, that's a very nuanced question. I think it very much depends on the viability of the patient and what the indication for the stent was. I agree with Chris trying to get this open and give it another chance. Some stents I'll fight for multiple times. When you have a complete occlusion of the stent, typically in these situations, I'm probably going to reline them with a covered stent at this point. And so my only hesitation is not trying to get a covered stent across the profunda origin in the process of treating this, but I think it's worth fighting for. Obviously, it's vocational limiting, and that's understandable.
Great.
Maybe one of the other panelists can weigh in. I mean, we've raised the issue of covered stents. We've obviously got other therapies that have RCTs as well, debulking, DCB, etc. Would anybody else do anything different? Lawrence?
Yeah, listen, I think Chris has demonstrated that, what we'll never know here is where the failure mode was. It's usually some form of focal stenosis, which then goes back to the flow divider. So unfortunately, then it ends up being the entire length of this thing being occluded. As a kid with a hammer, I would try to treat this as often as possible, but to some point, you have to really finally, bail on to surgery. But the challenge is when do you pull that trigger? And let's say that they do have good vein. I would say that if this is pure claudication, I would try to open it up. Marianne should be on this panel because, the Impact Global data would say you don't even have to debulk it. You can just dilate it and get a 1-year patency in the 90% range, even at 17 centimeters. So this is much longer. So look, I think at the end of the day, I would do this. I would like to debulk it. I would put a distal protection device despite it being, and I like Jetstream for this, just because there's a lot of crap in these arteries to treat. And then I would surveil them a little bit more aggressively and just look for the focal restenosis, whatever that ends up being as to the site, whether it's in the supera, if it was poorly deployed, or if it was in the alluvia up above. I would then focus on that to try to dilate those more often early rather than waiting for this occlusion.
Yeah. And I think you would agree,
Srini,
Lawrence, that most people would. Go ahead, Chris, go ahead.
Let me cut in, because what I don't want to do is have a panel discussion and we don't get our work done. So there's going to be times in this case I want to complete that. I think we're all on the same page. Give another chance, map the veins. Yeah. I like Lawrence said, we got across that. I was showing those while we're there. We put a distal protection. This is a NAV6 on a long bare wire. And then we're going to get to work. And then as we go, we can IVUS if we need to. I know Eric's a big proponent of that, and I agree with him. He was a smart guy. We'll see how that helps. And then we will decide together drug-coated balloon after this or relining. He's got 3-vessel runoff if we need to. And then finally, as we get to work, and we're going to go slowly with the device, so that's going to give you more time to bring expert opinions in or tell me if we're doing something wrong. But we're going to use the jet stream as well. Usually, I use a 2.1 to 3, but these are such large stents. We're going to go big and go 2.4 to 3.4, starting with the blades down and then blades up, going segment by segment. I think Rotarex would be another good option. Laser would be another good option. I do think distal protection, but let us get to work, and then you guys can continue with your opinions if that's okay.
Thank you,
So,
Chris.
great case. I totally agree with distal protection, especially if you are planning to use atherectomy. There should expect a lot of debris flying down. What I find very useful also for the cases like that, we know from the quite a good amount of data now that usually you have a plaques occluding the stent proximally and distally, and in the middle, in a relatively when the occlusion happened relatively a few months ago, in my understanding, starting from May, right? So it's all thrombosis inside, and what I find useful, I inject usually TPA through the whole entire stent over 035 catheter when just pulling back and injecting through entire length of the stent, and that helps you to prevent distal embolization. And I usually do it before I do any intervention. I usually use like 20 milligrams of TPA through entire lesion, and then balloon it just to get an idea where the tight spots are, and balloon can tell you the story, maybe how to better approach it, and then proceed with other. You see how it's like flying there? That means there's not much of a tissue there, or it's most likely thrombus, the jet stream.
Yeah, that's a good point, Anvar, because Lawrence, you said something about what's the failure mode here. And a couple of comments on this. The collaterals are pretty well developed, so clearly there was probably a chronic stenosis and then thrombose as proposed. But you can kind of feel with your device also where it's getting stuck, which is probably where that original lesion started and where you're going to probably spend the most time. And I won't talk about IVUS at the moment. Obviously, I'm always inclined to, but that will help define that failure mechanism. And then, Liz, back to your comment about covered stents. I think that's one really to dig into, because I think use of infrainguinal covered stents outside of a perforation is very low in the U.S. And I think a lot of the focus for restenotic approaches have been really drug-coated balloons with some sort of preparatory device. I don't know on the panel if others are commonly relining this with covered stents. The nice thing is you're away from the profunda, so you have the ability to do this safely for most of the scaffold if you wanted to, but probably wouldn't be my first approach. But I don't know, I'm open-minded.
I find that if you have a lot of class 1 or class 2, my first approach is going to be probably some sort of debulking, either laser or jet stream, and then DCB. I have found in my practice when you have long SFA stents that the patency is, once it's completely occluded, the patency is better with a covered stent. But I don't think that we know the right answer. I don't necessarily jump to a covered stent, like I said, when there's still some sort of flow channel, but I consider a covered stent when it's completely occluded and you have a very long occlusion of the stent.
Dr. Kuhn?
Yeah, I think, just thinking about covered stents, so for me, I think that the two issues with regards to the covered stent, it is a viable alternative, of course. Just looking here, because you really want to make sure you don't hit that collateral at the end, so it's going to be a little bit tricky, but potentially surmountable with a short landing, maybe a 5-centimeter Viabahn or something like that. But before I trigger a covered stent, I would like to do an IVUS and see if I can get lumen gain after high pressure balloon angioplasty, because we do know with the 2.4, 3.4, you're probably going to get maybe an effective 4 lumens. So before you think about it. In addition to that, with the superior, particular to this stent, it's fairly thick in terms of the strut. So I think that's one point. I do note I think these are very well placed stents, but if you look at the top, the Zilver was placed before the superior. So we can actually see the powerful drug-eluting characteristics of the silver, where the superior was probably implanted opposing the metal, but because of the negative remodeling from the drug, you can see that the superior is it's not really touching the metallic structure on the top. So I'll be really interested to know if that's something that we need to look at on IVUS. So that would be quite interesting. Is that a potential mode of failure? I have no idea. Yeah.
Isn't that the challenge with, if you look at the data, Viabond was always very big about, whether it was Vibrant and then ultimately Reline, right? And Reline said, you can stent anything and it has a great primary patency. In the real world, at least in our experience in Boston, it was awful when it came to long-term success, because long-term success by patency, the successes you remember, but it's the failures that you really regret. And those are the ones that tend to come back with acute limb ischemia. And I had look, we had somebody who used to put in a lot of them, and I took care of a lot of those failures early on. And the challenge was a lot of them lost some tissue. So it's the scientific data was one thing, but the real-world experience has been alternatively different.
Chris, can you feel where this is getting held up? It looked like at the transition in those distal superiors and now here.
Yeah, so a couple things. One, the architecture of the 6.5 looks really good. I agree with the overlap comments. And what we've done, okay, stop. We've gone blades down each. We took it by 3 segments. And we went blades down in each, and then twice, and then blades up in each. So we took it by segment and really tried to debulk, and now we've gone through the whole thing. We're going to come all the way back. A couple comments, and I'm going to give this to you, Sid, in just a moment. A couple comments. Go ahead, just hold this button and just take your time. Go ahead. And 1 sec, if you would. And I'm going, I want to show you the table setup in a moment, too. Stop. Okay, stop. Now just take it out like you would an over-the-wire device. You don't have to wreck it. Okay? Okay, come on out. So look at the table here. This is something I did learn in Ohio. I talked to these guys one time. They said, oh, yeah, we could do that. And we did for a live case. Notice that, normally, Srini and others, you've watched me do live cases for a long time. If I did a right leg, I would hunch under the table and just take the rads for the team. And honestly, I used to be 6'3", and now I think that's why I'm a little shorter than that. What we're doing now is we flip the table. So we got access here. But I don't know if you can show the cameras around here or not, maybe not. But what we've done is taken the consoles out in front of me and just simply pull the contralateral sheath up here, and we work from this side of the table, standing straight up and down, which I'm not 6'3" anymore, but the table and everything right in front of us. So it's a very nice way that's ergodynamic and a lot of better. I also like the thoughts that someone was saying about the lytics. If it was Viabond stents, that's what we do first time, every time, because often lytics alone is what you need. And it will solve the problem. You don't have to do anything. This was there since May, and I thought debulking was a good way to deal with this. And so now let's take a series of pictures, and then we're going to decide what we're going to do next. So help us here. Here's some pictures. We'll see what kind of debulking we got. And actually, it looks like there was a focal thing up at the beginning.
Yeah.
It's interesting. I'm going to let that play again. There's that very little tight stuff up at the very proximal part. So it is possible, and I want everybody to think together. And Liz, I heard your comment, and I couldn't agree more with, we're not going to cover the profunda if we do a cover stent. But the question is, do we balloon that? And then if it still has got debris there, then put a short 8x50 Viabond stent up there. And we'll get everybody's comments there. Let me back up a little. See, when I was 6'3", I could have reached that a lot easier, but now it's not so easy.
I think the main thing is I think your catheter and guide wire cross very easily, like we all suspected. So there's a lot of thrombus we're dealing with here, and probably maybe a focal lesion, like Eric and others had mentioned. Dr. Nakama, Dr. Finelli, any comments on how you would treat this in your practice or anything?
No, just a technical question. The first passage was blades down.
Yeah,
Because
good question. Yes.
What is generally my experience, especially for in-stent stenosis, you can do immediately blades up because you save time, and every time the blades are down, you have not a beautiful outcome at the end, and there is no risk of rupture as there is a stent in place.
Dr. Nakama, any comments?
I think personally, I believe the material in the zero PTX site and spiral site is completely different because in the bare metal, especially for the in the wound, spiral stent showed strong neointimal hyperplasia. It's not often contain the thrombotic material. However, in the zebra PTX site, it often contains much amount of thrombus. Therefore, we have to distinguish the two sites. So I think a deployment of the Bioban delines some of the part of the zero PTX. Sometimes effective, but I think that all these kinds of very complex situations, using the IVAS or imaging modality is very helpful to understand the detail of the morphology of the instant listeners. But anyway, use of the blaze up to debug the every material in the instant segment is very effective in this kind of situation.
Thank you. So I think for the trainees, I think you can see the consensus is debulking. You need some level of debulking. You want to get as much luminal gain as you can, and then there's various treatment options after the fact, whether it's DCB or relining this with covered stents. There's really no good head-to-head comparisons to show that one device is better than the other, so it really comes down to your experience and what you're used to. And remember that embolization is real, especially when you have long segment occlusions and dealing with ISR.
Yeah,
Dr.
I think
Bianchi.
for the trainees specifically, the debulking we're talking about is really thrombotic material in different stages of chronology. So, this is really Rotarex, like he said, laser has a class 1 application, class A, 1A, randomized controlled trial, is really a thrombotic. So it's not really a therectomy. The jet stream component of this is really for the thrombectomy component. And I think that's why they blaze up instead of the blaze down. Although I use Rotarex, which is, I think, a very powerful aspiration as well.
Yeah.
The other comment is you don't have to break the distal cap. You don't need a filter. So you can clean the proximal, leaving the distal cap, and then eventually go and then do what Anwar said. Give some lytics, make sure you melt all the stuff away, and then go ahead and break the distal cap.
You're talking about with Rotarex or just in general?
Just even with Jetstream, just leave
We
the
have
wire
a
proximal.
7x40
Yeah, that's
Dorado,
exactly
7x40 Dorado on a long shot.
Another thing is important for trainees, especially when you do your device exchanges, make sure you know where
many?
the filter is, because it can easily travel down all the way into the tibial artery, and the whole idea of embolic protection is gone then.
One of the things that we do with Jetstream, and we don't have a lot of experience with Rotarex, but if you don't break the cap, to PK's point, you can basically have that cloud of debris and just aspirate the hell out of that proximal segment, clean it up as much as possible. Then when you pop through, then obviously whatever floats in there is going to go downstream, and that's why your filter's there.
I'll say, looking at this angioplasty real quick, Srini, it looks like there's multiple failure mechanisms in these stents, though, because you can see how...
Looks like it's at the flexion point and a little more proximal.
You're right.
Yeah, Chris, so what do you think you want to do for that distal stent? Because it looks like it might need more debulking.
It's a good question. So I think what we're going to do first is we're going to balloon it and take a look. I think what we'll do is IVUS and see what's there. We cannot put a covered stent in until we've got everything fully expanded. Go forward there. Go up.
So I think we're going to do, Chris, if you're okay with it, we're going to do a couple of talks and then come back to you.
Yep.
Okay, that'd be great.
Perfect.
So, hi, Chris, can you hear us? Can you tell us what's going on?
We will use your wisdom here. Go ahead. Hang on one sec. Let me get you back to where we were. So, a couple things since you left. We first IVUS'd Eric, and I thought you with love in my heart. Unfortunately, when we rearranged the furniture here, the IVUS is not working. It gives me a snowstorm. I could see a little bit of snowstorm, but it wasn't what you really want to see is what's going on, and there's no fixing this. It's not Philip's fault. It's something that we rearranged everything. It got stretched, and it's unfixable. So you can see the IVUS catheter. You can't see much IVUS. I would love to show you an IVUS. All I saw was it's snowing in September in Tennessee.
So just to kind of catch us up, so you did 2 passes with Jetstream. Looks like you did POBA.
Yeah, let me review. Thank you.
Yep.
So Jetstream all the way up and down, blades up, all the way down. We got that relatively slow flow. Remember that Eric had mentioned the failure mechanism. Downstream, there was some narrowing within the balloon didn't expand all the way. So we ballooned with a 7x220 Sterling. I didn't want to commit to a drug-coated balloon if we're going to reline it. This is a Penumbra Bolt 7, Bolt Lightning 7, whatever they keep changing the name, but Bolt, the newest one. It didn't give us a lot of rat-tat-tat-tat, just at the proximal end, but that was it. And then this is a Dorado where it didn't expand. This is a 7x40 Dorado at 25 atmospheres. And there's one area down there which didn't expand as much as we'd like. Remember, it was a 6.5 Sapera to begin with. And those were the only areas that didn't expand before, so we hit those with a Dorado. And now, before we take our next step, what I did is put a Navicross down there, left our wire in, and took a picture downstream. By the way, clinically, he's fine. I mean, he's got no symptoms, moves his leg, motor, sensory, warm foot. So now we've got that picture. So there's for sure debris in the basket. So then the question is, go ahead and reline this with Viabonds now, because there's probably debris in there. Use the penumbra to get the basket out, which we're going to do anyhow. But do we get the penumbra, get the basket out, and then reline? The other option would be to get the basket out with penumbra, suck it out, put a lytic catheter in overnight, and finish tomorrow. And so let me get a couple thoughts from the panel here. Should we reline? If we're going to reline, do we do it before we get the basket out? We're not going to shower much down with the Viabond in place. And then we could Viabond it and then get the basket out with penumbra. That won't take us long. And then if there's still issues, leave a lytic catheter in overnight. What do you think?
So let's ask our panelists. So just to summarize, so you're assuming there's still some debris or thrombus within that segment of FemPop that you're treating?
Well,
because it looks pretty good right now. I mean, we don't know what it looks like proximally, so why are you thinking covered stent automatically?
Go ahead. The proximal part, let me go back one more thing that's very important. Here's the proximal part. You know, the flow is not so great.
Got it.
Right there. Now, what we could do, and this is where Ivis, Eric, you're spot on, we could just put a short Viabond up there right now where the problem child was to begin with. That one fully expanded. So why don't you get us to 8x50 Viabond? The only thing, if we're putting an 8, I want to put that into a 7. So, but we could put a quick, why don't we do this? Why don't we put an 8x50 Viabond there, take the penumbra down, get our basket out with aspiration, and then reassess.
Okay, so maybe I can talk to our panelists too while you're doing that. So any thoughts on this at this point in terms of how you would manage this current situation?
Yeah, Chris, I think the reason why the flow is not that great, probably because your basket is absolutely full. The moment you remove it, I have a feeling it's going to look much better. In terms of removing it with penumbra, what kind of size of the catheter are you using? Are you using Cat 6?
Yeah, Cat 7. I'm sorry, Bolt 7.
Cat 7?
Which will be beautiful. And so we've already got it open. I've already used it. So it's easy enough to, do you want to just take that out? Let's do that. Let's take our, I know I switched my mind. She said, you're not a woman. You can't change your mind that much. We could certainly just, let's take our basket out, see what it looks like. It'll be easy to wire again. And then we can add Viabonds as needed.
And Chris, you said the Ivis isn't working currently, right?
That is.
It's not working. Okay, so that's we just want to make sure. So Eric, Dr. Coombe, anybody, Dr. Finelli, Liz, Dr. Genovese, any? I assume many of you would Ivis here in this case, see what's going on.
I would do exactly the plan. I would take that basket out. And see what's going on. I mean, the risk of stenting right now is if you stent and you still have this outflow, now you have a fresh, covered stent in there without outflow. So you just want to really make sure you have some flow before you that covered stent in, because then you're stuck kind of chasing your tail there. It doesn't seem like there's too much thrombus left. I think Srini, you said that as well to start. So a lytic catheter may not be necessary. I mean, Anvar's comment about maybe a couple milligrams of TPA just in case there's
open that up.
You need to clean out the rest of that basket or anything else residual isn't a bad idea, because it's not going to cause much harm to the patient. But a lot of options here, I think, to get out of this with a clean.
Dr. Genovese?
And there's something's a little funky with that proximal portion. You see how the contrast is getting hung up there. I don't know if there might be a little fracture in the stent we're underappreciating, or just dissection behind the stent with the aggressive angioplasty. But I totally agree. Take the filter out first. See how actually everything flows.
Yeah, how things look.
Don't assume it's just because the filter is full.
So, Chris, we're going to go to a few more talks while you're working, just because we got to get through some interesting topics.
No, I think so. You should.
All right.
That'll give you a little peace of mind, anyhow.
Hi, Chris. Can you give us an update?
Yeah, we sure can. So The panel was brilliant. Even Eric, and I got to say that. So this was the penumbra. We went down again, and we got the basket out that was, remember, full of debris. Okay. And so then here's pictures after that. You can see that the flow looks really good. Okay.
This was so basically you just removed the filter and did
Yep.
not place that covered stent proximally.
Correct.
Okay.
All right. So you can see good flow now. Now we haven't done anything yet to treat the restenosis factor. So we decided, because especially without the IVUS, we went back and put in a NAV6, and then this is a 7x200 Ranger, and an overlapping 7x200 Ranger, and you can see we overlap there, and that's where we are right now. And you're ready to see, hopefully, halfway pictures. If not, we've got a little cleanup work, but we should be, Lord willing, just about done. So, good advice for the panel. I will say for all you guys who do live cases and gals, the one thing I don't like to do with live cases is clot, because it just doesn't play fairly sometimes, or thrombus. And note to myself again here. But we got good tools to work with it. And all right, so thanks to you all, and we'll get you some downstream pictures. And what I'm going to do is show you downstream, and then we'll do all the cleanup work. But I know you've had a long time with us, so appreciate that, Srini and everybody. This will take a moment. I should have. And again, that's all been treated with a 7 drug-coated balloon. So let's go down to trifurcation, and we'll do runoff here in just a second. This is where I missed my 6'3" days. Okay. And so good news is the trifurcation's fine. Remember, every time I've done runoff, even when we had the separators and everything at the end, there's kind of sluggish flow down there. So we'll take pictures of the feet and everything here. If there's anything different, we'll show you in our next case. But for your session's sake and for our room turnover sake, we should probably end things here. And again, Srini and panel, wonderful advice. I think the good news is we did not leave covered stents behind if there was flow issues, as was suggested. We got everything out. IVUS would have been helpful. We'll get that fixed hopefully by the next one. And then drug-coated balloon technology. So lots of stuff to get that cleaned up, and hopefully with smoking cessation and good medical therapy, he'll do fine. Would anybody put him on low-dose rivaroxaban in addition to his other meds now?
Real quickly, if you could just raise your hands. Low-dose rivaroxaban, aspirin. Yep, you got it, Chris. Everybody agrees.
Yeah, I kind of figured.
Well, thank you, Chris. Another
Well, guys,
great case. Appreciate it. Thank you.
Thank you all very, very much. Thanks to the team here.